My name is Getachew, a PhD student at Jimma University, Ethiopia. I would like to thank you for giving me an opportunity to present the Ethiopian ICEMR. So my topic was effects of unsupervised low dose of primaquine treatment on Plasmodium vivax relapse and Plasmodium falciparum transmission interruption in Ethiopia. We do have three objectives in this study: to evaluate effectiveness of unsupervised chloroquine plus primaquine treatment in preventing relapse of Plasmodium vivax. And the second one is to evaluate the effects of unsupervised chloroquine plus primaquine combination treatment on Plasmodium vivax infectiousness to mosquito. And the last one is to evaluate effects of single low dose of primaquine treatment on Plasmodium falciparum infectiousness to mosquito. When we see a clinical trial result of Plasmodium vivax recurrence in Ethiopia, two clinical trial results showed chloroquine plus primaquine treatment significantly reduced the risk of recurrence than chloroquine alone, and effectiveness of chloroquine plus primaquine treatment on Plasmodium vivax recurrence in real-world setting is unknown in relation to primaquine compliance, immunity to vivax, and genetic diversity of vivax. Therefore, we conducted an observational cohort study on Plasmodium vivax for 1 year. So the malaria treatment guideline in Ethiopia for Plasmodium vivax, chloroquine plus 14 days of primaquine administered, whereas for Plasmodium falciparum, ACT plus single low dose of primaquine administered. So the study was conducted at Ajodi Desai irrigation scheme in the surrounding locality. Malaria is endemic in the area, and the proportion of Plasmodium falciparum and vivax almost similar. And for this study, 12 health facilities from 3 districts were selected within a 20-kilometer radius, 1 elimination district, primaquine provided by the health facility, and the 2 non-elimination districts, no provision of primaquine by the health facility. So we use this as an advantage, and we conduct the study. So the primaquine were administered unsupervised. So patients were briefed about chloroquine and primaquine treatment, how much taken, when to take, change in urine color related to hemolysis, and the primaquine was compliance was taken actively on 3rd day, 7th day, and 14th day by counting the remaining PQ tablet. This picture you see one of our data collector checking the primaquine, counting the primaquine while at field visit. So the follow-up schedule for P-vivax was at the enrollment where the patient received chloroquine alone or chloroquine plus primaquine were checked. The primaquine compliance were checked on day 3, day 7, and day 14. And venous blood sample were collected for membrane feeding experiment. G6PD were measured, and other tests were done at the day of enrollment and in the subsequent visit for 12 months. And a total of 203 Plasmodium vivax cases enrolled in this study, and 49.7 were in chloroquine only group, and 50.3 were in chloroquine plus primaquine group. The mean age of the study participants were 19.7 years with a range of 1 to 56 years, and the majority of the study participants were male due to the study were conducted at sugarcane irrigation scheme. So when we come to the chloroquine plus primaquine compliance, the majority of the study participants, almost 82.4%, complete 40 days course, whereas 70.6 didn't complete with a range of 3 to 13 doses. When we see the impacts of chloroquine plus primaquine treatment on vivax recurrence. As we see the survival graph here, the x-axis indicates the duration of follow-up of the study participant, and y-axis indicates the proportion of recurrence. And the top line, the blue line indicates chloroquine plus primaquine complete group, whereas the red one indicates chloroquine only group, and the bottom, the green one, is chloroquine plus primaquine incomplete group. So the median recurrence time for chloroquine only group is around 150 days, and the 19th percentile, or the worst case for chloroquine plus primaquine completed group, is around 90 days. So chloroquine only and chloroquine plus primaquine complete were significantly different. So when we see the table, when we see the recurrence rate in the table, the recurrence were higher than in chloroquine only group and chloroquine plus primaquine incomplete groups than chloroquine plus primaquine complete group. So the time to first recurrence in chloroquine only group was so earlier than the chloroquine plus primaquine group. When we see the total impact, completion of 40 days course primaquine lead to fourfold reduce odds of Plasmodium vivax recurrence related to chloroquine alone. Fewer doses of primaquine were not effective as 14 days. So when we come to the membrane feeding experiment or infectiousness experiment to Plasmodium vivax, at the baseline, the mean mosquito infection rate were similar in case of chloroquine only and chloroquine plus primaquine group, because this experiment was conducted prior to any treatment. So after treatment or post-treatment on day 42, in chloroquine only group and in chloroquine plus primaquine group, the mean mosquito infection rate were significantly different between the two groups. So chloroquine plus primaquine significantly reduced Plasmodium vivax infectiousness to mosquito. When we come to the falciparum study, CT treatment does not get much suicide, which contribute to transmission of artemisinin-resistant parasite to mosquito vector. Therefore, addition of a single low dose of primaquine kits match with gametocyte to prevent onward transmission. Therefore, we conducted an observational cohort study on Plasmodium falciparum for 28 days. So the follow-up schedule for Plasmodium falciparum were at the day of enrollment, we checked whether the patient received ACT alone or ACT plus primaquine were checked. The PQ compliance as well as venous blood sample were collected at day 7 for membrane feeding experiment, and the other tests were done at the day of enrollment and in the subsequent visit. For this study, a total of 804 Plasmodium falciparum cases were enrolled. Among these, 43.3% were in ACT only group and 56.7% were in ACT plus primaquine group. And the infection experiment on Plasmodium falciparum on day 7, the mosquito infection rate were different in ACT and ACT plus primaquine group. And the ACT only is much higher than ACT plus primaquine group. Therefore, addition of a single low dose of primaquine to ACT significantly reduced Plasmodium falciparum infectiousness to mosquito vector, more than 90%. In summary, approximately 10% did not comply the 40-day primaquine treatment course in case of Plasmodium vivax patient, and 40 days full course of primaquine reduced vivax recurrence rate by an odds ratio of 4-fold, whereas partial dose was not effective. And addition of single low dose of primaquine to SCT treatment regimen reduce Plasmodium falciparum infectiousness through mosquito by more than 90%. The implication, improving compliance in PQ medication in case of Plasmodium vivax patient, and support single low dose of primaquine practice for Plasmodium falciparum transmission control by giving health education and promotion to malaria patient, and by involving health extension worker to improve PQ compliance and intake, and finally by empowering the community. Thank you for your attention. This is my presentation.